Hello, everyone. Happy Wednesday. We are starting with our IG Live. Today's going to be super interesting. Let's see, we're waiting for her.
Hello.
Hello.
Hi.
Hi, Melanie. How are you?
I'm doing great. How's it going, Lily?
Good. Welcome to the Brain PT.
Thanks.
Welcome
Thanks
to
for
the Brain
having
PT
me.
chair. So I am so excited about today's topic because one, a number of people contact me and they were like, I'm so excited. Is it going to be available afterwards? I'm going to turn on the countdown. So thank you for
I
being
love that.
here.
Yes,
Yes.
my joy. I'm so excited to be here.
So everyone, this is Melanie. I'm going to tell you a little bit of Melanie. So she's a neuro PT on a mission to integrate her passion for wellness, preventive medicine, and functional integrative medicine with the world of neuro PT. So she's a wife and she's a mama to three kiddos. What are their names?
Olivia, William, and Rosalie.
Oh, so sweet. So sweet. So she recently relocated to Dallas, Texas, and she is looking to find some new opportunities to collaborate with other professionals to provide patient care for individuals across the lifespan
Yeah.
with a neurologic diagnosis. So if you're in Dallas, contact
Holler.
Melanie.
Yeah.
Yes,
Let me
yes.
know.
So, and then after completing her residency in neurologic physical therapy at UT Southwestern School of Health Professions, she joined the staff of the Gait Disorders Clinic there in the physical therapy school. And then later, she joined the faculty as a faculty associate, where her focus, in addition to the Gait Disorders Clinic, was in multidisciplinary clinics for pediatric care. Pediatric care of people of kids with rare neuroimmunologic diseases, adult MS,
Hmm.
and vestibular disorder. So, wow, so
I'm
great.
crazy.
Thank you.
Well,
Thank you for
yeah.
being here.
My joy.
Um, and today, Melanie and everyone, we are going to talk about this topic that there's just so much to it. Like, we're going to talk about knee hyperextension, during gait. And we see this a lot of times
Yes,
in the patient
absolutely.
population, specifically neuro population, okay? And mainly stroke. We see it a lot after stroke.
Yes.
But also, if you're a sports specialist, orthotherapist, you might see this in, even the younger population, the elderly, knee injuries or
Hmm.
genetics. So, I mean, that's another conversation for another
Sure.
time, but
Yeah.
I am going to pass the ball to you. We're going to talk about and learn about knee hyperextension
Yes.
during gait, specifically stance.
Stance phase of gait. Yes. Well, so Lily, I was just looking, I pulled out the old trusty, I'm gonna try to show you because I'm sure you've seen this before, but the
Yes.
good old the good old observational gait analysis. I don't feel like I can talk about anything that's deviating from normal without thinking about normal gait, right?
Right. And here we
So,
have a little comment. I am the
oh,
queen of knee hyperextension. Help from Allison. Allison, we got you. Okay. We're going to
yeah,
tell you a
I
couple of
hear you,
things that we.
Allison. Yes. That okay, I'm learning. Now I am learning, Lily, how to read
Yeah, you could just
these.
scroll
Yes,
up and
okay.
down.
Awesome. Yeah, so you are familiar with this with the observational gait analysis book, right? So the
Hmm. Hmm.
two big things that I kind of reviewed and would say are really important to think about when we're
Hmm.
thinking about stance phase stability,
Hmm.
um, is what's the torque demand at well, let's go back a little bit. So obviously knee hyperextension, when we think about knee hyperextension, you may just automatically assume that we need to address something at the knee, right?
That's where I tend to go.
Yeah.
I'm like knee,
Yeah, exactly.
yeah.
Uh, but if we think about what's actually happening in that phase of the gait cycle above and below the knee, so at the ankle and at the hip, we'll hone in on the ankle. But what's happening at the ankle is that the greatest torque demand in the entire gait cycle is happening at terminal stance at the ankle. So when
Yes.
you are when you're in stance phase, it's hard to do this without showing my foot and ankle right now. But when you land in stance and your tibia starts to progress forward, our plantar flexors are what is firing and what is stabilizing us in
Right.
normal gait at that
Yes.
phase, right?
Yeah.
So that's why we have to kind of for a second forget about the knee and move on to considering the ankle. So that's one thing. The next thing, if you know that piece of information, you can go back to the knee and remember from our trusty observational gait analysis book that the knee actually, when the contralateral limb is swinging in the gait cycle, once it passes the contralateral limb, it allows your quadriceps to turn off in normal gait, allows your quadriceps to turn off. So they are passive. There is a knee extension moment happening as that limb is swinging forward. So if we think about all of those things with regard to normal gait, and we try to translate that into, okay, now I've had a patient who's had a neurologic injury, and like you said, we can kind of specify stroke, or we can start there at least. What should we look at? What should we consider? Well, like you also said, there are so many things to consider, but one big thing to consider is look at the ankle. How stable is the ankle after someone who has sustained a stroke? If you try to test dorsiflexors, what are you going to get? Pretty much zero. If you try to test plantar flexors, what are you going to get? No activity. So, and the same would go for lateral movements, inversion, eversion. If you don't get any muscle activity at the ankle, it's safe to say the ankle is unstable, right?
Right.
So could there be things going on at the knee? Certainly. But from my experience and just from that of who has trained me and my mentors and people that I've worked with, it seems to be a safe place to start at if we think about the ankle. Yes.
Just so I can make a little comment for I turned off the comments, but if you guys have any questions, I'll turn it on at the end. That way we can address your questions. Just wanted to let them know.
Perfect.
Okay.
So Lily, what does that, any questions from what I mentioned so far? Okay.
No.
Tell me what your thoughts are in terms of, or what moving kind of past considering normal gait, where do you have, or where have you heard the most kind of pressing questions, or where would you like to go from that?
Yes. So that was a great start, because in my experience, and sometimes I find myself doing this even now, I see someone with that thrust or, that knee hyperextension, and we automatically think, that knee is super weak, that quad weakness, and we start to focus on the knee too much. And truth is, like, it is, like, I agree with you, it is least likely to be a weak quad unless there's weakness like throughout. And if your patient can hold a like squat for like a couple seconds, their quads are too strong. Okay.
To
Like,
consider. Yeah, sure.
we need to start looking at other aspects. So, like, I guess some of the questions that I've heard, it's like,
Mm-hmm.
okay, should I focus on like quad strengthening? Should I first address ankle? And sometimes with these patients, we do see like very severe or significant muscle weakness, like the foot drop, or even those 0
Mm-hmm.
MMTs. So, or like ones, twos. So, like,
Mm-hmm.
what kind of interventions should we do? Should we start with
Mm-hmm.
to address the ankle when these patients are already, very weak,
Yeah.
and they might not be able to go through the full range of motion of an exercise?
Mm-hmm.
Should we focus more on like task specific exercises, where we can see some ankle, activation, like sit to stands, blah, blah, blah. So,
Yes.
how do we start with the
Yes.
ankle
Okay.
specifically? So, here we're going to talk about the ankle, guys.
Yeah. So I mean, the big, I think everything you just asked, oops, sorry, everything you just asked could be summed up in considering task specific exercise. Uh, I have never met someone who has had a stroke who, let's see, I don't want to say this and not, and second guess myself. Everybody that has had a stroke, generally, the primary goal would be to get back to walking.
Mm-hmm.
There may be other things in there. There may be some, more functional things specific to certain scenarios, but overarching, walking is what people want to get back to, right? So
Mm-hmm.
to
Mm-hmm.
make their exercise task specific, then therefore our goal has to be to get them walking. So how
Mm-hmm.
do we do that in a way that is safe for them and achievable for them? Is we have to provide an environment that allows them to get, you think about those neuroplasticity principles, those the fact that they need repetition, that it needs to be task specific, it needs to be salient. It is because they want to get back to walking.
Mm-hmm. Mm-hmm.
And especially if we're going to kind of target stroke and early intervention specifically, I'm a big proponent and just have seen in practice bracing, early bracing.
Mm-hmm. Mm-hmm.
So following, and it's, I think a lot of, I was actually just reading that have you seen the new, sorry, this is a side note, the new clinical practice guideline that just came out
For the
about
AFOs.
AFO and FES? Yeah.
Mm-hmm. Mm-hmm.
So that study and a lot of kind of systematic reviews and really large studies, I think, do somewhat of a disservice because the types of braces are not, I mean, they can't be. I understand that. It's very difficult to kind of follow that with that large of a study, what type of brace is used.
Mm-hmm.
But using something that will address kind of what we talked about, right? So there is going to be likely foot drop. So they do need assistance, Dorsey assist. There
Mm-hmm.
is very likely weakness in the calf muscles. So we need support and stability on both sides of the ankle joint.
Mm-hmm. Mm-hmm.
So are you familiar with, we haven't had a chance to talk about bracing prior, but are you familiar with a double adjustable AFO?
Mm-hmm.
Does that
Yes.
ring a
Yes.
bell?
Mm-hmm.
So I don't know if everybody is. So I have a little demo here. But this joint is a wonderful resource for this population, and especially acutely and subacutely,
Mm-hmm.
because
Mm-hmm.
it's adjustable. It will allow Dorsey assist, but it also will allow, like I said, it's
The plantar
adjustability
flexion stuff.
to allow there to be forward motion of the tibia and to train that into um, to a person's kind of task specific training specifically for these people. That would be for gait training. So yeah, that is those that joint specifically, early on, being able to set up the environment in a way that someone would be able to use a brace like this, or bracing in general, to provide dorsey assist, to allow for motion that's usually is going to be in a pretty controlled environment. So like treadmill, or, you know, a walker sort of setup to allow for additional like manual assistance from a therapist or two or three sometimes. You know, yeah. Does that,
Yeah,
is that
so
helpful? Yeah.
overall, guys, plantar flexion, strengthening, and, you know, bracing if it's very significant. Okay.
Yeah.
Now let's go up a little higher and let's talk about the hip. What
Okay.
might be happening at the hip?
Well, okay, I'm going to stop you for 1 second because I forgot to mention one other thing at the ankle. So I'm going to reference that CPG really quick again. You know, it talked about FES versus AFO, and I feel like, you know, STEM has been underutilized. I feel like as neuro PT, or I have been guilty of underutilizing
Same.
STEM, because I feel like it can be so helpful for folks. But sometimes the question comes up: are we focusing on the wrong muscles to provide STEM to? So, you know, a lot of the commercial devices out there are providing dorsey assist, right? So I guess the question, and there isn't, this is just, I'm just posing a question to the audience, but something to consider, and maybe others are considering it or trying it, but what about trying STEM to posteriorly, so to the calf muscle, at the proper time in the gait cycle? So in that mid stance phase, when you are working on knee stability, when you do want those muscles to be firing, why not stim them to give them that extra input? So another thing that can be used in conjunction with bracing, possibly. I think the biggest issue with that, if anybody has considered this or attempted it, what you've probably found is that it just logistically is very challenging. The devices out there are not the most user-friendly. They aren't, in terms of like being able to position electrodes properly underneath a brace, that kind of thing. But definitely, I think is a resource and you know, a great thing to
The
consider.
electrical stimulation. Yeah, because
Yeah.
we
So
usually you know, I'm guilty of, you know, always thinking of, oh, you know, e-stem to the tibialis anterior, you know? So yeah, we should think of, you know, if there are any students or any therapists, can we electrically stimulate the posterior muscles? Okay.
yes. Yeah. Okay.
So
So back to the hip.
what about hip? Let's
Yeah.
say they have hip extensor weakness,
Yeah.
which they mostly they all do.
Yes.
So
Yeah.
what can happen if they have hip extensor weakness?
Yeah. That is a great question. So, I mean, I would say cueing, obviously, if it's weak, but they're still upright, and, you know, and they're still able to ambulate, then again, you're wanting to get more repetitions of a, you know, as close to typical walking, typical gait as you can. So are they, if they have weak, I guess you said you've discovered they have weak hip extensors. So you can isolate, you know, strengthen those in isolation, but also more, I guess, kind of more of a priority would be to get them fully upright. So those folks may be, you know, might be leaning
Yes,
pretty significantly
lurching
forward.
forward.
Yeah. So think about what your gait device, I mean, what your assistive device options could be, right? So if they're using something like a rollator or a you know,
Or
four-wheeled
even a
walker of some
walker.
sort,
Yeah.
any sort of rolling walker, that's just propelling them forward. So think about forearm crutches as an option, or a cane, or something that will promote
Or the
better upright
platform.
posture.
Yeah,
Yeah,
yeah.
or the bilateral platform rolling walker,
Mm-hmm.
absolutely.
Mm-hmm. And
Earlier on.
I love the bilateral platform walker. Some people might not, but I love it because it promotes symmetry and it
Absolutely.
promotes upright posture. Now, not all patients will come up upright. Some of them, they like to be like this, and then
Yeah.
you cue them and they come up here, and then okay, they go back.
Yeah.
But if you don't have a good trunk posture, so that's the other important thing, guys. Posture is important. The trunk will translate the body weight forward, and then the knees will extend, and that will
Hmm.
promote
It's
the.
that knee extension moment again, similar to what we were talking about in normal gait. Yeah.
Hmm. Hmm.
Um, and I'm so glad you brought up the bilateral platform rolling walker, because that for anyone who maybe is familiar with kind of some of the research that has been done in early stroke intervention. So that task specific training following stroke. So
Hmm.
using the bracing to help control and support the ankle, but also if a treadmill for kind of that repetition isn't available, isn't an option, a bilateral platform rolling walker is a wonderful
Hmm.
alternative option.
Alternative,
So
yeah,
yeah,
yeah, yeah.
so yes.
So
What
hip
else?
extensor strengthening. So what about tightness? Well, we're going to go back down to the
Mm-hmm, mm-hmm,
ankle.
mm-hmm,
So, guys, if you have foot drop, if you have weakness of the plantar flexors, okay, if you have all those, please count that 100% of the times they're going to be tight on their calves. Okay, so you need to stretch.
yeah,
So, what
yes.
about tightness? Tightness,
Mm-hmm,
and what can you say? How does like tightness, and this also includes like when they have spasticity on the
mm-hmm,
quads, and
yeah.
they're tight. So what do you recommend for those folks that okay, they have spasticity, so that's creating
Yep.
some biomechanical factors contributing to
Mm-hmm.
the hyperextension. There is some extensor synergies. What should we do in that case?
So I will say from experience, when you get a person upright, so on the mat, you test them, they have significant spasticity.
Mm-hmm.
That might be understandable, but you get them in a an upright position, in a position in which they can achieve closest to typical gait that they will their body will allow at that stage. Um, those things, I wouldn't say that it fully resolves, but it will diminish the issue
Mm,
that I have seen with spasticity. So there are outliers. There can be outliers, but most of the time, I will say, when you get, especially at the ankle, when you get them um, seated, get that foot seated in the base of a brace, um, that is it's a prolonged stretch, which is what
mm-hmm.
they need. But
Mm-hmm.
B, it is that positioning, um, which is biomechanically correct,
Mm-hmm.
will relax that force of spasticity that you're seeing in a mat
Mm-hmm.
evaluation. Um, so all that to say, I think it is obviously it's very typical for us to see after a brain injury, for us to see significant spasticity. And I
Mm-hmm.
think that, I mean, I have been guilty of this, but I think it's so easy to get kind of hyper focused on that and want to try to rid them of
Yes.
it.
Mm-hmm. Mm-hmm.
But the options for that, are more medical,
Mm-hmm. Mm-hmm.
medication options, and those don't typically, I mean, they may already be on baclofen, or they may already be considering those through the care of their physician, which is fine. To a degree, that's a different conversation, but I don't think it needs to be
Like putting our
necessarily,
PT
yeah,
blinders.
yeah,
Okay,
no,
spasticity,
you don't need to focus so
Mm-hmm.
significantly on that. So that's what I
Yeah.
have to say about this.
Yeah. Yeah, spasticity, it's not the only thing
Yeah.
affecting gait when you have, someone with a neurologic condition. So
Yes.
anything else that we might be missing? So we talked about check the ankle, okay?
Mm-hmm.
Check the strength of the calves, because yeah, we know we might see dorsiflex
Mm-hmm.
weakness, but
Mm-hmm.
calf, okay, don't forget. We talked about posture, okay? We
Mm-hmm.
talked about hip weakness, because the hip will support, the limb when it's in stance and the other leg it's in swing, okay?
Mm-hmm.
We talked about, are there any other factors like spasticity or tightness that it's contributing to that hyperextension? And then, of course, there might be some quad weakness, but like I
Mm-hmm.
said, if they can maintain a squat for a couple of seconds and not fall,
Yeah.
their quads are pretty weak. So anything
Or
else that we
strong.
might be, or yeah, or strong. I mean, sorry, yeah, their quads are strong.
Strong enough.
So is there anything else that we might like use to help us with this problem during their gait? Because I feel like when they have this problem, um it kind of affects the knee joint. Everything is stretched
Yes.
out, and ligaments are allowing all the force going back. And then
Yeah.
something that I just learned is when they do go into hyperextension, the calves turn
Turn
off.
off.
So you don't
Yeah.
want your calves
Not what
turned
we
off.
want.
We
Yeah,
want
no,
them on.
this is that. So your question, or kind of what you were just talking about, it does affect the knee joint. Like we can't, even though we need to look above and below, we can't ignore what's happening at the knee joint
Right.
when that
Mm-hmm.
is especially chronically, right? So I think it's really helpful to think about this, on a continuum. So
Mm-hmm.
depending upon the population that you work with, or maybe the type of clinical setting that you're in, you may have a different set of considerations. So,
Mm-hmm.
I mentioned the double adjustable AFO, which in in the case of stroke, I have used early to late across the continuum pretty successfully.
Mm-hmm.
There
Mm-hmm.
are obviously, if you have somebody coming to you who has had a stroke and their it's a chronic condition, they are greater than a year out, say, and there is profound knee hyperextension.
Mm-hmm.
What I mean, just from my own experience, but also what the evidence kind of points to, is that our chances of being able to have a significant effect on changing that gait pattern, for a successfully for a long, like over time,
Chronic. Mm-hmm.
we're fighting an uphill battle, right? So we
Mm-hmm.
do need to look
Yeah.
at the knee joint. So that's when you do consider something more mechanical, right? So
Mm-hmm.
you can try taping. So there's the Leuko tape that has no give. It's not like
Mm-hmm.
kinesio tape. It's something that would provide a very stiff um,
Leukotape.
Leuko tape. Yeah, are you familiar?
Mm-mm.
Yeah, so it is, and I can send you that, but that's what I have used.
Mm-hmm.
And
Mm-hmm.
you do it like an X behind the patient's knee. So that's like
How
a
tight, or do
proprioceptive.
you like
Yeah,
pull?
like 10 to 20 degrees of knee flexion,
Oh, okay.
and
Oh, so it provides
hold
the
their knee.
sensory piece.
Yes, yeah. So it's just
Okay.
going to be sensory. On a small, like a small frame, small build
Mm-hmm.
person, you may get some actual control for a time, and then over time they might start to push through it.
Mm-hmm.
Another
Mm-hmm.
thing to consider chronically, or if that the knee hyperextension is pretty aggressive, they have like a thrust pretty
Mm-hmm.
consistently and just
Right,
very,
right.
and one
Yeah.
thing we didn't really talk about is sensation. Really poor proprioception, poor sensation. A Swedish knee cage. Are you familiar with that?
Oh,
I should
yes.
have
Uh-huh.
grabbed an
Uh-huh.
example of that, but using that,
Let me
so
see if I can
using
find
that
one
in
so I can
addition
show.
to bracing at the ankle can be a good combination.
And this is good for let me show people in case if they don't know
Yeah,
what it looks like. Is this something like you can, I mean, yeah, you can buy online.
you could, but I mean, patients, if they wanted to try to get insurance coverage, just get a prescription from there. Yep, that's it.
Mm-hmm.
So it's like that is not something. So while the conversation with the brace that we were talking about earlier, the ankle brace, we're talking about trying to regain typical mechanics, right?
Mm-hmm. Mm-hmm.
With the knee cage, that is a mechanical stop. So it's not something that
Mm,
is designed to, so it's a totally different consideration, right? So it's not designed
mm-hmm.
to retrain or be able to potentially get out of that
Mm-hmm.
knee hyperextension, but it can
Yeah.
slow and minimize the thrust,
For that
which is
knee, yeah.
meaningful. Yeah, absolutely,
Mm-hmm.
because of, like you said, over time, the wear
Mm-hmm.
and tear on that knee joint that's important to consider.
Mm-hmm. Right. And here I'm gonna show the leukotape for, is
That's
that
it.
it?
Yeah. So if you use that, I wouldn't put that directly on patient's skin. I would grab some like Metapore or like
Mm-hmm. Mm-hmm. That medical tape,
the white kind of medical tape to put on directly on the skin, and then you put liquid
and
tape
then
over
do
that.
the, yeah. Okay.
Yeah.
Okay. Well, guys, that was great. So, summary. Summary for, let me turn on the comments in case someone has a comment of like any patient they have. So, okay, I see knee hyperextension. My alarm goes off. Okay. I check the ankle. You most likely will find calf weakness. Okay. We can bet on it. Okay. All right. Once you check the knee, the ankle, you check the hip. Okay. Of course, you're going to check the knee and now, even like knee pain, because they might have some pain because if they thrust,
Yes.
yeah. And then how's their posture? Okay. If there's spasticity in the quads or in the extensors, is there any like biomechanical factor that's impeding motion? Okay. Because with spasticity, we might deal with range of motion issues. Okay. Is there any sensory issue like proprioception, loss of sensation, all those? And then, of course, the motor planning, which we didn't, I mean, this is like all of it, right? Because we're teaching to walk again.
Mm-hmm.
And, we everything motor planning. Tightness in the ankle, I forgot also. Is there any tightness on the
Yeah.
ankle? And then, I feel like a lot of people, including me, we love like intervention ideas. And yeah, maybe we can talk another IG Live on just like exercises that we can do, like, the task specific exercises, which are maybe our favorite calf exercises. I didn't include that a lot here because it's going to be a long video, but we can talk about it in another time. But,
Mm-hmm.
you always think about the impairments. You don't need a fancy intervention to treat plantar flexion weakness or,
Right.
tightness, things like that.
Yeah.
Anything else that you want to add, Melanie? Maybe we should plan that one. That would be a good
Yeah,
episode.
I think that's a great follow-up. That's a good round two.
Right.
Round
Yeah.
two.
And we're PTs, we love talking about gait. I love talking about gait. I
Yes.
love looking at people walk. And
Yes.
just today, I was looking at a patient at the rehab, and she is learning to walk again. And they braced her, and she looked wonderful. Don't
That's awesome.
underestimate, guys, the power of the bracing. Okay,
Yeah.
her terminal stance, like heel lift, was beautiful. Her
That's
heel
awesome.
strength.
Yeah.
So, guys, brace if you have the support, from your PMR doctors and all of them.
Yeah.
And, if you feel that they are good fit for a brace,
Yeah. Yeah.
yeah,
I mean, I guess I will add finding an orthotist that you can
yeah.
have kind of that two-way communication with and work with is gold, is really helpful. And
Mm-hmm.
someone that kind of you guys can have those theoretical conversations, those kind of understanding gait on the same level is so helpful. And to be able to collaborate in that way is really great. So yes.
Great. Well, thank you so much for all the knowledge and all the information you have given us.
Yeah,
Anything else
you
that you
bet.
think like, this is like, you need to know this guy?
Nugget.
Like anything else that you want to add before we say goodbye and we plan the next one?
I don't think so. I think this is a good note to end on.
Okie dokie. Well, thank you so much, everyone, for joining. Thank you, Melanie, again.
Yeah.
We should be planning another one soon. I hope you have a
Sounds great.
wonderful afternoon.
Thanks. You too. Bye,
Okay.
Lily.
Bye, guys. Bye, Melanie.
Bye.